A very good evening to all our participants here. We are back, and this time with a very interesting topic and a very warm, friendly, and interesting speaker again. While we unmask the pathogens in our fight against them, while we take a new approach to change the whole diagnostic paradigm and the way a clinical microbiology laboratory provides services to the clinicians for better patient outcomes, let me welcome very wholeheartedly, and it's an honor, it's a pleasure to have Dr. Aneesh with us for the talk today. He's the principal scientist and head for the Center of Genomic Medicine, NIMS Medicity Hospital, Trivandrum, one of the pioneers in the science and one of the very early collaborators with us. It has been a wonderful journey so far, working hand in hand, trying to change the infectious disease scenario in Kerala, Trivandrum. So Dr. Aneesh has an envious biodata. It's huge. So I'll just summarize it. He is currently heading the operations of the Center for Genomic Medicine, NIMS Center for Genomic Medicine, which is a comprehensive genetic healthcare facility integrating consultation, diagnostics, research, and training in medical genetics and genomics. And he has completed his master's and PhD in molecular biology from the University of Madras. He holds a postgraduate diploma in bioinformatics and has a master's in international business management as well. He's an NABL certified internal auditor and an authorized signatory for medical laboratories. Diverse areas of research interests. He's already making waves, doing great work. So over to you, Dr. Aneesh, to take up the session. Looking forward to it.
Thank you, Dr. Mahua, for that generous introduction, I should say. Thanks to everybody at Haystacks for giving me this opportunity, to speak about something which is very close, close to my heart, and especially, but close to any clinical genomicist who's working in the area of disease diagnostics. I think all of us appreciate the fact that post 2020, genomics has invaded into the prescriptions of doctors on an everyday basis. And when earlier it was affordability was an issue, accessibility was an issue. Nowadays we have broken that, and I think in that field, Haystacks is doing a wonderful job, and the NIMS is very happy to associate it with you guys in launching this test, being a pioneer, as you mentioned, in this part of the country where this is unheard of. I'll just begin my presentation on that note. Is my slide visible? Okay, right. So good evening, everyone. Happy evening to all of you. And today, the topic which we are going to deliberate on is basically unmasking the pathogens, metagenomics approach to infectious disease. Now, all of us know very well, especially the ID specialists or microbiologists in the audience, they are very familiar about they're very familiar about the commonly used pathogen identification systems. But let me just go through that, before moving forward. So the options that we have available currently, of course, the one which we refer to as a gold standard is your regular blood culture. Now, which is based on the principle of growth and isolation of the species, giving them a media, and then, you have to literally culture it. So that's how the principle of a blood culture goes about. And of course, if we talk about the affordability of it, it is quite affordable. It's not very expensive. Now, there are major hurdles with that, which is what is led to the exploration of newer technologies. Now, also in the case of they're very medium dependent. In case of fastidious organisms, you will be required to have specific components in the media for specific growth. And also, if there has been a prior antimicrobial therapy, that will also affect the sensitivity of the culture method. Of course, it takes a lot of time, which is the biggest issue as far as infections in hospitals are concerned. Like especially in a scenario of a septic shock, a clinician cannot afford to drag hold on to deciding. So they end up giving empiric therapy, and that's what is being observed in most of the cases. The second strategy that we have is immunological methods, be it via the antibodies or antigens. Again, cost is not a major factor. Time is also not a major factor, but the yield is the major factor, because in case of acute diseases, and this antibody testing may not yield. And also, if we look at the antigen part, they are limited by its specificity and sensitivity. So that's also a hurdle that we face. Then comes to what Dr. Carrie Mullis gave us quite a few years ago, which formed the basis of molecular biology, and which formed the basis of genetics and genomics, and all of these updates that we see now is basically thanks to the development of the polymerase chain reaction technology by Dr. Carrie Mullis way back in 1980s. Now, of course, when we talk about PCR, we are looking at the targeted amplification of specific pathogens. So it's of course culture independent, but then it requires us to know what we are looking at, or possibly looking at. So that is one thing. Cost is, I won't say very affordable, but affordable. Then the limitations include it being limited by the specific primers, the panels which will have the specific primers. And then also it detects only few selected microbes, and some species might be preferentially amplified. So if you are looking at something which is there but not part of your panel, you may miss it out. Turnaround time is also not an issue with PCR. Then comes the hero of the story, our metagenomics, where basically we have made it quite easy for the clinical fraternity out there, where it is pathogen agnostic. You don't have to look at or judge what exactly you're looking at. And the principle is basically it works on the DNA barcoding technology, or the metagenome technology, where we look at the nucleotide sequences, which is captured and amplified. It is, of course, a little cost-wise, probably you can say it could be, in standard areas, it could be a little more expensive compared to your cultures. But then, looking at the advantages, you will definitely feel it's negligible. Microbial detection is totally unbiased. And of course, if there are contaminations, and if the pipeline is not properly streamlined, then of course the even because of its high sensitivity, it may pick up contaminations also. So you can't just gulp down the report that comes down from the instrument. You have to have a judge to find out if what's happening is what's getting detected is correct. And of course, turnaround time is about 12 to 24 hours. So yeah, as I mentioned, the gold standard, what is considered as the gold standard, is blood culture out of all these. Even now, when a patient enters the ICU, in suspected cases of sepsis or any infection for that matter, be it bone and joint, or be it aspergillosis, or whatever it is, the first or any fluid for that matter, the first option that comes to a clinician's mind, a prescribing clinician's mind, is blood culture, the culture method, which is of course time consuming, and the sensitivity and the yield is pretty low, as all of us know. Now, low clinical sensitivity, especially for the fastidious organisms, and also a poor guide to pathogen diagnosis. And the major hindrance that we face is it cannot detect unculturable organisms. So only those organisms which can be cultured are picked up by the culture method. So that is why the sensitivity of the blood culture is pretty low. Now, looking at PCR technologies, it is definitely dependent on the clinician's diagnosis. So the clinician should know what they're looking at, or possibly looking at. Based on that, select a particular panel, and that panel has a small detection range. And if there are any pathogens which is not part of the panel, it will precisely, it will not be able to pick it up. So, of course, it depends on amplifying nucleic acid sequences or the DNA or RNA. And there is a need for a specific primer design. Now, amongst all this enters this concept of clinical genomics, where we are looking, clinical genomics is basically a discipline where we look at the genomic information as part of the clinical care. So it could be diagnostics, it could be therapeutic, it could be prognostic, and it could be looking at the host or the individual as such per se genomic information. It could be looking at the microbiome information, the about the organism's genomic information. But whatever it is, we are looking at the genomic information. So that is what clinical genomics is all about. So what is metagenomics? So when we talk about traditional microbial genomics, it basically requires you to culture an organism, isolate an organism, then culture it, and then go ahead with sequencing the genome of one organism at a time. And this is always dependent on the organism growing in the media. Okay, that is how we look at a whole genome sequencing or a traditional microbial genomics. Now, the case in our hand, the technology that we are currently discussing, basically is referred to as metagenomics, which looks at the metagenome. Okay, so it extracts directly from the sample. There is no culturing in between. It directly extracts your total nucleic acids, your total DNA material from the total community per se, and then it is the specific regions are amplified. For example, bacteria we would be looking at the 16S rRNA, ribosomal RNA, that is 16S subunit of ribosomal RNA part of it, mostly the V3, V4 variable regions. And as far as the fungus is concerned, we would be looking at the ITS or the internal transcribed spaces. So now, when I'm talking about barcoding, what exactly is a barcode? Like, all of us have been to supermarkets, right? So when we go to a supermarket, we have certain products which are picked up, and you see, and all of us have seen the black and white lines where there's a scanner, and as soon as the cashier scans this barcode, the information about the product is flashed on the screen. And how many ever products are there in the supermarket, when you scan a barcode, only one specific information is given, which is very, very specific to that particular product. Something like when we were in college, we had a college ID, right? So when we look at the ID, when we enter the ID into the system, it's only our information that comes, however old the college is, right? Or an employee ID for that matter. So these barcodes are very, very specific. They are considered to be universal identification markers or DNA-based markers, which can be used in identifying or doing a molecular taxonomy of the organism. So what we do in metagenomics is basically look at that particular variable, that particular region of the organisms all put together. So we need not individually pick up. So whatever sequences get amplified, that's subjected to a database search, and then we come across with the identification of the organism. So that is what we are looking at. So where we bypass the need for culture techniques, sequence the entire DNA in the sample, and then look at these specific regions, and then go ahead and search it against the database. So why are we looking at next generation sequencing, or NGS? This is an open platform where we are providing the opportunity to detect bacterial and fungal pathogens in a single assay, especially the rare opportunistic infections, even in immunocompromised host. Now, when we're talking about rare opportunistic infections, from personal experience, I should mention the test that we're currently talking about that even picked up Nordella, which is an organism which is quite quite rare and wouldn't have been picked up if we are looking at some other form of testing. Now, this is data-driven diagnosis, and there's no requirement for any premonition of the suspected species. That you need not be a judge of what could be possibly there and stuff. It is unbiased and untargeted, so benefits from any DNA sequence information within the patient specimens. So higher sensitivity and specificity. Now, the platform that we are using currently is the Oxford Nanopo technology, which is the third generation one. So recent developments have shown that even larger amounts of DNA in shorter times, and this has the potential to be a point of care application. And there is no need for specific primer designing, and it's very effective in detecting co-infections. That again brings me to another case that we had a look at, where we in a tumor patient, we were able to look at polymicrobial infection as part of the report, and that was very well appreciated by the clinician, because had they undergone any other test, they wouldn't be able to come out with such specific results within short period of time. And I won't say not affected, but less affected by the prior empiric therapy, and very accurate, comprehensive, rapid. Now, accurate because it gives you the identification at a genomic level. So not only the species, but at the genomic level, identification is what is given. Comprehensive because we don't have a panel concept. So all the while we have been used to selecting panels, like what does this panel cover? Does this cover, is this organism included in this panel, etc., etc. So when we are looking at an NGS based approach or metagenomics based approach, we are looking at a comprehensive approach. If it is a bacteria, theoretically it can be picked up. If it is a fungus, theoretically it can be picked up. That's the situation. So that is why we call it a comprehensive. Rapid because we don't need to wait for 3 to 5 days to get a sterile report like a culture. That is why we get the yield technically within 24 hours. We are sending out our reports, and that's why the clinicians are pretty happy about it. And can directly detect thousands of fragments in a single test. And so you basically reduce your battery of tests. Suppose you select a panel and then you don't get anything, then you suspect there could be another organism, then you go ahead with another panel. So all that is surpassed when you're looking at an NGS, because all of this is happening at the same time. So I need not repeat the sample with multiple panels. And that again not only saves time, but also saves the amount of material required, the clinical material. All of us know the clinical material that we are looking at is very delicate. Like, for example, a CSF or any fluids for that matter. When it comes to the volume which can be taken up for testing, we have to be very stingy about it, right? So we can't afford to have batteries and batteries of tests till we find out what are we looking at. So most of the time, NGS is a solution that way as well, where we can look at smaller volumes because we run the sample. It's a single test which detects all. Now, a quick look at what happens at metagenomic sequencing. So basically, when the biological sample is drawn and it is subjected to nucleic acid extraction, then there's something called as the library preparation, followed by a sequencer. Then the sequencer generates the raw sequencing files, which undergoes a lot of QC and alignments with the databases. And finally, the result is basically identification of the species at the bioinformatics stage. I mean, the final bioinformatics stage is basically where we have the name of the species in front of us. So this is pretty much what is happening here. So if any of you happen to come down at NIMS and have a look at the team doing this, this is what is happening throughout the night. And it's an overnight procedure to so that we can get back to the clinicians at the earliest possible time, and they can that they can help in patient care. So what does research say, or what does the studies across the globe say? Is it of course this is a a test which is Haystacks is the first one to launch it in India. And but then there have been a lot of studies across the globe, and there have been a lot of scenarios that have been shown out. I'm just showing you a snippet of what we found. We looked at papers which showed the importance of metagenomics in a central nervous system infection, where the samples could be a cerebrospinal fluid. We looked at sepsis, both and shock as well, sepsis and the septic shock as well, where blood plasma was the primary candidate for testing. For respiratory infections, we looked at the BAL, we looked at pleural fluid, we have seen tracheal aspirates, then abscess, for the peritoneal fluid. For we have even tested urine samples. We have come across literature for urine samples, and a lot of musculoskeletal joint fluids as well. So all these scenarios have been explained, and there are n number of papers across the your databases which show you that metagenomics is the go-to test for the future if when it comes to infection detection. And I'll just quote a few of the literature before we move further and try to see what's happening. Like this paper where they have compared standard of care microbiology diagnostics in patients suffering from septic shock. They found that in contrast to blood culture with a positivity rate of 33% at sepsis onset, the positivity rate of NGS-based pathogen identification was 72%. Now that's a huge yield, and you can obviously understand that when we have such a good yield coming out of this test, basically that is going to help a lot in patient care. I mean, sepsis has been a cause of mortality, a very strong cause of mortality across ICUs, like what we have seen. So this could be the answer to that. This could be something where we can help out the clinicians in reducing the mortality among the patients. Now, over the whole study period, blood culture positivity was 11% and the NGS positivity was 71%. So that is the amount of difference that we see. Coming to another paper, where they have again compared sepsis with blood culture, the positivity of NGS and blood culture was 62.5 and 14.5. That's NGS was 62 and blood culture was 14.5%. So, in fact, in this paper, they go on to mention that difficult to culture microorganisms such as pneumocystic girovaccae, and it was identified in 2 patients, leptospira in 1. So all this indicates the possibility of using for translating this wonderful technology into patient care. There's this one where we talk about the application, which talks about the application of metagenomics in orthopedic infections, where the number of patients they had recruited was 49, and the presence of bacteria was found to be in 36 out of the 49 patients, which translates to 73%. And in case of traditional cultures, it was 29 out of 40, about 59%. So again, difficult to grow microorganisms such as slow growing anaerobic bacteria were better detected by NGS compared to the traditional culture in the study. So when we look at the benefits and the weaknesses of NGS and culture for orthopedic infection, the benefits is, of course, when we look at the current microbiological techniques, the techniques are widely available, can be performed in most of the microbiological lab with the basic equipment. So any microbiology lab, you can have a look at culture method. That's, of course, a very big benefit because that looks at the accessibility. As far as the NGS benefits are concerned, the higher sensitivity, specificity, decreased time for pathogen identification, and identification of the organisms present independent of the prior antibiotic use. Weaknesses, the current techniques where they fails to identify organisms that are viable but not culturable. So we are not able to identify, then requires very specific medias and conditions, risk of contamination. And if there is a contamination, there's also a chance of that contamination becoming predominant over the actual pathogen, and we may be misled with the results, false positive results. And then the large fraction of microbes cannot be grown with culture. So as far as NGS is concerned, of course, it requires specialized equipment, trained technicians, and a bioinformatics expertise, which is needed. And I think that's where the whole point of haystacks come in. It's an automated proprietary pipeline, as we will be looking at now. This is another case where we are looking at the comparison of pathogen detection. just yeah. Where we look at pathogen detection, again a comparison. Where if you see the NGS group shows about 65% positive samples, whereas the blood culture group shows us 13.13% positive. Now this is a Nature paper which again substantiates our belief in metagenomics. Here we look at BAL, where 35 BAL samples were taken into consideration and compared with the culture method. The metagenomics had a diagnostic sensitivity of 88.89% and a specificity of 74%, with an agreement rate of 77% between these two methods. Now, compared with the smear method and PCR, metagenomics had a diagnostic sensitivity of 77 and a specificity of 70. So 34% cases led to changes in the treatment strategy. And that is what we are looking at from a clinical point of view. So before we move on to talk about the test, I would like to show you something which will actually be a better introduction about the test and what we are doing at it, first-hand experience. We bring to you an interesting case of timely and accurate diagnostics using genomics technology in saving the life of a critically ill patient admitted to NIMS Medicity Trivandrum.
We had a 73-year-old lady coming from the outskirts of Trivandrum, close to NIMS Medicity. She had fever for more than 1 week, intermittent. She also has history of diabetes and hypertension. For the past 3 days, she also complained of cough, breathlessness and abdominal discomfort. She had been to 2 local hospitals without any diagnosis being made, and she was finally referred to NIMS Medicity. She came to our emergency unit and she was examined and was found to have high-grade fever with a low blood pressure of 80/60. Her diagnosis of septic shock was made. Immediate resuscitatory measures were adopted in the emergency room, and she was shifted to our multidisciplinary ICU for further evaluation and management.
At this point, a primary provisional diagnosis of sepsis was made. She was started on inotropic support, injection meropenem and injection doxycycline. We also sent a consultation for Dr. Sharik, our AD specialist.
The workup was planned for infection screening. Relevant cultures and serology was sent.
As per the current scientific evidence, we know that next generation sequencing, which we call it as NGS, is the way forward in this scenario, because the patient was in shock and I needed a result in short time. So that's where we called Dr. Aneesh, and this facility was available in NIMS Genomics Center. So we called Dr. Aneesh, and then we immediately sampled the process, the blood, and sent it to the NIMS Genomic Lab for next generation sequencing to detect fungal as well as bacterial pathogens inside the blood.
The blood for the patient was received for infection test, a next generation sequencing test which detects pan-bacterial, pan-fungal and medically relevant antibiotic resistant genes. The committed turnaround time for the clinicians was 24 hours.
So as we were waiting for the next generation sequencing result as well as the blood culture result, the scrub IgM ELISA came back as positive. However, there was a twist in the story. Her CT abdomen was showing right pyelonephritis. So it was really confusing for us whether it is scrub or whether it is the pyelonephritis which is the reason for the septic shock. Now the result of next generation sequencing is back. It showed Orientia Susugamoshi. So the whole confusion, the whole clinical dilemma getting solved there, and now the clinical team is convinced that this is basically scrub typhus and not pyelonephritis, and we stopped all the unnecessary antibiotics and continued treatment with the scrub typhus with this patient. So scrub typhus is a rickettsial disease which mimics lot other tropical infections like dengue, leptospirosis, endemic fever. So diagnosing it in the early phase is still a challenge because it's not culturable. Second thing is that serology becomes positive only after the 7 days. And here in this case what happened was that we nailed the diagnosis straight away by identifying the Orientia Susugamoshi, which is a reason for the scrub typhus, from the blood using NGS. And then we could stop all the antibiotics. We could stop all the unnecessary antibiotic and focus only on the scrub typhus treatment. and the patient showed dramatic improvement over next 72 hours. We could stop off all the inotropes, and the patient improved well with just doxy plus azithromycin or the anti-scrub treatment. So the way forward, the world is facing a lot of problems with the antimicrobial resistance and antibiotic abuse. Next generation sequencing appears to be a tool which actually helps a lot in precision medicine than empirical based treatment. So this platform, this NGS platform is on the way, and we are actually on a way to have more precise diagnosis before putting the antibiotics.
Right, so I'll get back to the slides. Yeah, I think it's visible now. Yeah, so moving forward, we are talking about a test called infexn, very correctly named IN with just a small change in the spelling. So what is the test we are talking about? We are talking about infexn. So we are finding infexn at NIMS Center for Genomic Medicine here. This is a genomic solution, a pioneering genome sequencing based test, which has been deliberated and brought out in the market by the company Haystack Analytics. And there are certain advantages. Like, first of all, it is direct from the sample. We promise a TAT of 24 hours, and we have been sticking to it. To tell you, we have been actually doing this test since November, if I'm not wrong. And the response from the clinicians, of course, we started off with a lot of apprehensions in the beginning, but then we had a validation phase. So there was an in-house validation of all the samples, and then followed by the going live with the test. And we have been doing it like there hasn't been a single day where we are not doing it. So basically it's run every day, and that has been giving us a very good yield and a very positive response from the clinicians, because at the end of the day they are the ones who have to take a decision. And it has been giving a good result, a good yield. So this test is basically pan-bacterial and pan-fungal. So as I mentioned earlier, this is not a panel-based test where you say we recognize 25 pathogens or 40 pathogens or even 1,000 pathogens. This is, if there is a bacteria, it can be detected. If there's a fungus, it can be detected. Theoretically, that is it. If it's not getting picked up, then there could be other reasons to it. But as per the technology, it should be able to pick up. So if there is anything which is not getting picked up, then we have to, of course, troubleshoot it. And the most important part of it, it also covers very important antibiotic resistant genes. We cover about 9 of them, and that has also been very helpful, because traditionally antibiotic resistance is dependent on culturing and the phenotypic assessment of the cultured organism, of the selected cultured organism, as I should say. So here we don't have to look at that. We direct from the sample. So you give me a acetic fluid. We basically find out what's the organism present. If there is an organism present, what is the organism present, and if any of these ARGs are present in that. Of course, it's not a complete coverage of all the antibiotic resistant genes, but then the 9 significant ones are covered. As I mentioned, it starts with the sample collection, which is transported to the lab, and then there's a DNA extraction happening, followed by pre-sequencing preparations, and then that's library preparation, and then finally it goes into the sequencer, where through which the data is generated and the analysis is done, and then it's an automated report generation, which is finally approved by a microbiologist. Sitting to verify and then compare the clinical case and give the report. The samples currently accepted are any sterile, as in aseptic, any body fluids which are drawn in aseptic conditions. It could be blood, it could be bile, it could be any intraoperative collections, peritoneal fluids, pleural fluids, CSF, you name anything which is aspirated, we can have a look at it, including urine from a stent, or even aspirated internal pus, or all of these fluids are getting covered in it. Now, if you have a comparison of this test along with a regular culture method, or a regular molecular panel method, or a Sanger sequencing method, the first and foremost is the TAT. That's the best part about infection, because it gives the best TAT amongst all of them. Now, why I'm saying that infection gives a better TAT than the molecular panel is because of the comparative coverage. Because of course, a molecular panel for a PCR to be done, even if it's multiplexing, the exact TAT would be comparable. But then if you compare the other advantages, if you say that we are looking at all the bacteria together, then the TAT of infection is the best. Range of pathogen, of course, no doubt. We look at the infection as the best option. I'm sorry about there's a slight error in the slide. That's not that I'm colorblind. I happen to miss that there's a green spot given for the culture. No, the range of pathogens in the culture is should be red. Actually, it's very poor. Then coming to antimicrobial resistance, infection picks up. Sensitivity, specificity, and local, as I mentioned, it has a huge potential of being a point of care technology where the patient gets admitted to the ICU, and then we are able to do the test on the same day, as near to the bed as possible. So that's quite possible with the technology. When it comes to the procedures and the requirements for sampling, we accept, or we require, about 8 ml of whole blood in a sterile EDTA vacutainer. Now, that can be a single vacutainer or multiple vacutiners, that doesn't matter. It's the whole total amount which is required, which has to be 8 ml. If you're looking at any other fluid, be it bile or CSF or any intraoperative collections or any fluids, we look at a minimum volume of 4 ml as a sample volume. Now, of course, collected with very strict aseptic conditions and in a very sterile container. If you look at if you ask me what are the possible fluids that can be taken up, then you can look at synovial fluid, where we look at the fluid, needle aspirate, or culture of any specific joint, knee, ankle, elbow, hip, wrist, etc. Internal body sites, we can look at specimens obtained from surgery, or aspirates from any of a lymph node or a brain or heart, liver, spleen, vitreous fluid, kidney, pancreas, ovary, vascular tissue, etc. The list goes on. And the most important part is the proper and strict aseptic conditions, which has to be observed while collecting the sample, and also storing the sample. When we are looking at invasive procedures, it has to be very, very strictly aseptic, so that we avoid colonizers or contamination with skin microfloras and all of that. Of course, it has to, as with any biomedical sample, it has to be a sterile leak-proof container. Now, another main thing that's required here is a cold chain. Even if the sample is getting stored or it's getting transported, a strict cold chain of 0 to 4 degrees. So if you happen to collect the sample at night, and if you're not able to transport it immediately to the lab, you may store it, but only at 0 to 4 degrees, which is nothing but your regular refrigerator. Now, this is how the setup looks like. I'm only showing you the sequencing part of it. The entire molecular diagnostic setup looks quite different, where you will have your DNA extractions and the hoods and the PCRs and all of that. Here, this is what is the look of the instrument on your table. As far as the sequencer is concerned, it's very I should say minute, as small as a hard drive. and the sequencer is as smaller than your mobile phone. So that is what it looks like, where you have a flongle, and that is fitted onto a flongle adapter, which is run on a MinION sequencer from Oxford Nanopore. And the sequencing data is analyzed by a fully automated proprietary bioinformatic pipeline, which is installed in the box that comes along with it, the hard disk that comes along with it. And this is how a sample report looks like, where you have all your patient identifiers to start with, and then it will, the first page will tell us both what is the pathogen identified and if there's any class of antibiotic resistance that's identified. So the first page gives you a whole snapshot of the entire report. Cumulatively, it comes to about 3 pages, where you further down you have the details of the reads. Because as a clinical genomics study, a test, you should be looking at the number of reads, which hints at the like, I wouldn't directly say quantify, but then of course gives you an idea if that's a good amount of read, if it is good enough to taken for consideration. Also, if it's a polymicrobial infection, you can look at what is the more predominant species present there, and then you can also look at your antibiotic classes to which it is resistant, and all that is picked up, and that is what you will have your adapter details and all that. But from a clinician point, I think it's more about what is the pathogen, what is the resistance that's detected, and how good are the reads. So all that is covered there. So in my experience over the past 4 months, the preferred samples that we look at is basically blood in sepsis cases, CSF if it is showing high neutrophil count. So here I forgot to mention, so the test currently covers, if you ask me what is the disadvantage with the test would currently cover only the bacteria and the fungus. Of course, the head of R&D and the team, like Amrit and his team, and even Dr. Mahua has promised me that very soon we'll be including viral. I'm hoping they stick to their word. And because once that's done, then honestly, it would become a universal identification system. You think of an infection, and the next word that comes to your mind is infection with an X. So CSF, if it shows high neutrophil count, because if you're suspecting anything to do with viruses, currently that's not getting picked up here. Then pleural fluid, again, if it's neutrophil predominant and exudative effusion. Acidic fluid, again, with a high neutrophil count. BAL, especially in cases of invasive, pulmonary invasive aspergillosis, you could have a look at through the BAL, which could be, helping us out. Even bone and joint infections as well. That's something I missed out. Now, to summarize, I hope I'm in time. Yeah, okay. It's exactly 45 minutes. I'm correctly on time. So NGS, when compared to cultures, has been shown to give us a very good yield, and has, as I mentioned, has given us the results in a very acceptable turnaround time. And that has led to a lot of help with the patient care. Then the high pathogen identification in septic shock, sepsis, bone and joint infection, and BAL samples, shorter turnaround time. And as I mentioned, it's not just identification; it's a genomic level pathogen identification. So you get the exact name of the organism, since we are looking at it from a DNA point of view. And of course, we don't need to send sets and sets of blood, so lesser volume of blood needed when compared with blood cultures. Thank you, and I'm open to questions.
Thank you so much, Dr. Aneesh. We already see on the chat a number of questions. It was very interesting. The talk was great. Many insights shared, a real life case shared, which makes it all the more interesting. So we'll take up the questions from the chat. We have a question. Can bacteria, virus, and fungus be sequenced at the same time in cases of mixed infection?
Okay. So yes, I see that's Ms. Deepthi Krishnan. Yes. So as far as metagenomics is concerned, yes, it can be sequenced at the same time, because though we use different areas of the genome, Like as I mentioned, when it comes to a bacteria, we'll be looking at a 16S. When it comes to fungus, we are looking at an ITS. So we'll be looking at different areas of the genome, but it can be parallelly taken up. And that is the whole advantage of metagenomics. Coming to virus, as far as metagenomics is concerned, bacteria, virus, fungus can be sequenced at the same time. But if we are talking about this particular test that we are working on, currently, as I mentioned, Dr. Mahua is yet to give me the option of virus into it.
Which we will soon do, because the intent is, as Dr. Aneesh has described, it should be a one-test solution, so we don't compromise and split samples. We should have answers from a single test for the clinician in real time. So yes, that is our intent. We should be able to include it soon. That is the beauty of metagenomics. The second question, antibiotic resistance can be detected. I think you've already mentioned.
Yeah, so we've already discussed this. Yes, antibiotic resistance can be mentioned. This particular test covers 9 of them. Going forward, probably we'll be looking at a larger coverage, so to answer most of the requirements. And I think that's quite possible. Yeah, with like metagenomics, if apart from the clinical scenario, if you look at the One Health concept, where even resistomes are getting screened in effluents and stuff like that. So where we are looking at the entire antibiotic resistant genes which are present in your effluents, or even if they are from residential areas or from livestock areas. So yes, metagenomics has the capacity to understand the entire resistome. Resistome is basically all the set of antibiotic resistant genes. So yes, that can be detected.
Which again is a very valuable concept, because once we know about the plasmid mediated resistance from the resistome, we know that is very soon going to affect all of it. So
exactly.
These are the jumping ones. Okay, you have some questions around the cost, if you want to take it up.
Okay, how much cost of this genomic solution per samples? I don't know about the other centers, but then currently it is in our Trivandrum NIMS Center for Genomic Medicine. It's priced at 12,500, which I believe is a very, very affordable rate for all the results that you're getting. That's the current rate. Yes.
Right. There is a query by Ms. Aditi, but analysis takes time. Can use for special cases, but not feasible to use for routine use. And Dr. Aneesh has experienced the analysis time himself.
Right. So Aditi, in fact, analysis takes time. It applies to other options available. Here, the major advantage, as I have been talking from the beginning of the webinar, the advantage is that we are getting the results by next day afternoon. So though we say 24 hours, the team here starts the run by around o'clock approximately, depending on the sampler oil, but approximately 6 o'clock. And by morning, the snapping is done. And by the moment I come into my office early morning, like around, not early morning for me, which is usually around 10 to 11, the results are on my phone. So that's the amount of, so you sleep over the analysis is what I should say. So yes, that's
Aditi, if the question was specifically around the bioinformatics, so what is that analysis? So that is our intent. That is why we have automated it, so that the software can take away from the investment of time that a person-mediated analysis will take for such huge data.
Exactly.
So it's actually 5 to 6 minutes per sample.
So the time required is for the sequencing part of it to get the reads. The analysis is shortened thanks to Dr. Anirvan and his wonderful team.
Absolutely. Okay, so I think in continuation, she's just posted another question. Can we use this technology for research, as in detecting the multiple genes leading to AMR in urine culture?
I can't see that question.
She's just posted it. It's way down, but I think it's in continuation.
Can you use this technology for research, as in detecting the multiple gene leading to AMR in urine culture? Of course, yes. And that's happening across the world. I think that's where this all started. So, whenever we look at any diagnostic platform for that matter, that is a translational version. So it all starts with research, and then once you see a good yield, and then there's a lot of validations and there are a lot of approvals that goes into the process before it gets into a regular clinical diagnostics. So yes, if you want to go back and use this for detecting certain genes in AMR genes or antibiotic resistant genes in urine culture can be done. The same resistome screening as we were talking about.
Right. A question by two of our participants about mycobacterium. So will this test be able to solve the query about mycobacterium, and what is the volume of samples required?
Okay, so coming to mycobacterium, as like I was looking at the data, mycobacterium, of course, is a challenge when it comes to, as in theoretically, the technology will pick it up. But when it comes to a practical application, the issue lies with the extraction part. So because of the bacteria being a tough thing to crack, but then yes, we believe that, and I think we have seen also that this test is picking up mycobacterium as well. MTB has been picked up, but again, that's because, as I mentioned earlier, theoretically, yes, any bacteria, any fungus will be picked up. If it's all there is something missing out, that is because of standardization required in the extraction procedures, or if there's any PCR inhibitors in the sample or something like that. Yes, mycobacterium will be picked up.
Right. So we have, do you use your own proprietary software, or do you use the pipeline provided by Nanopore?
Okay, so I think Dr. Mahua is better to answer with that, because that's between haystacks and Nanopore. I don't think they will be interested in diverging that.
So the hardware is by Nanopore. The base calling is by Minnow software. But the bioinformatics is a proprietary software owned by Haystack. It's our IP. So that is Omega Suite.
Right.
Okay, Dr. Shine asks, any clinical studies done on this test? So.
Oh, yes. So as I mentioned, this is a current routine practice in our hospital and quite a few hospitals in and around, this part of the country, where we are getting, one second, wherein we are, getting samples on a routine basis. Now, clinical studies, we are in the process of currently running 5 to 6 clinical studies. Apart from our validation, which is already over, we have already done a validation with different samples. Apart from that, specific clinical studies are in progress, where we are looking at septic shocks, sepsis, invasive aspergillosis, pulmonary aspergillosis, and then we are also looking at SPBs, and I think there's one more which is not right now coming to my mind. Yeah, so 5 is what we are looking at. That's in progress. So we are in the process of doing that, and again, it's a multi-centric clinical study that is happening. This is apart from the the validations that happened.
So on every table that we are, Dr. Shine, just to add to what Dr. Aneesh has already mentioned, we have had internal validations, and all of those were always clinical samples. We have performed a huge clinical study with Breach Candy hospitals in Mumbai. The data is already up for publication. We have already submitted the first draft. So we should be in a position to share about the details very soon, once it is accepted. So this is what, and very fortunately, one of our studies from the initial days of validation that has been accepted in the Journal of Applied Microbiology. So the test has been validated. So, okay, is sputum one of the samples that is being accepted? Is the query?
Okay, I think.
You want me to take the question?
Yeah, sure. Please go ahead.
Very purposeful.
Please go ahead.
So while you see, actually, this test can work on any sample, but for samples which are rich in microbiome, simply because of the fact of the way they transit out of the body, they collect a lot on their way. So if we look into urine and sputum as a sample, while they are being evacuated, you can say, from the body, they pick up the commensal flora. So there what we see is a microbiome. Now this test would pick up whatever is there. That is the power of this test. But the clinical decision making becomes very challenging in such a situation when you present to a clinician a microbiome. So to pick what is the pathogen versus what is a commensal or a commensal flora that has been picked up is a challenge. We are trying to solve that at our R&D end. Once we are able to do so, we should be able to involve these samples which inherently have a lot of microbial flora. So skin swabs, sputum, midstream urine, these are some of the samples which have inherent microbiomes. So currently, no, we are not including it as one of the sample types, but we should be able to. So we don't want the test to be very discriminatory. We want it to be inclusive, and we are working our way around it. Okay, there is another question from Amol. What is the correlation of the number of reads and proportion of reads with the pathogen detected? I think Dr. Aneesh has already mentioned it,
Yes.
but you can again.
So the correlation between number of reads and proportion of reads with the pathogen detected, how we correlate is basically, this is again like if you remember, how do I put it? Basically, it's like the CT values where we're talking about real-time PCRs, or basically it can be called quantitative, but authoritatively we don't, we don't quantify using that. But yes, it can be related, and if it's very few in number, if the reads are very low, we generally know that we have our suspicions, and if the read is reasonably acceptable, then we know that yes, this is what we are exactly looking at. So that's how you correlate your number of reads. Where if you have and especially in polymicrobial infections, where we have 2 or more bacteria detected, if we are looking at one with about 500 read and the other one with about 1,600 reads, then we definitely know the one with the 1,600 reads is the predominant species in the infection. So that's again another way of correlating.
So I think there is a question around the ability to detect NTLs. Similar to mycobacteria, the thought is same. What about the resistance gene in case of mycobacteria? I think the other product line is better at it. Omega TB is the answer, and we can connect to you, sir, and present you with those details.
Yeah, I'll just quickly take that up if you don't mind, Dr. Mahua.
Absolutely, please do.
So, in fact, why? Because that's the first product I collaborated with Haystacks on. The thing is, if we are looking at a complete coverage of all the 18 classes of antibiotics, as far as which is, a wholesome coverage of the resistance pattern in Mycobacterium, then they have another product where they do a whole genome sequencing of TB. Now, the only issue is this detects, the current test, the infection test that we are discussing here about, detects MTB. But of course, we won't be able to give you the entire, repertoire of the entire spectrum of antibiotic resistance as far as Mycobacterium is concerned. For that, you will have to have a culturable Mycobacterium inoculated into a MJIT tube, and then once it grows up, we subject that to a whole genome sequencing, and that covers all the 18 classes of antibiotics, which is actually more applicable than infection. Dr. Mahua, you're on mute, I guess.
I'm sorry. So the question is, do you run this test on histopath samples?
Okay. Again, so as we mentioned in the beginning, as of now, we are looking at any aspirated, aseptically drawn, sterile body fluids. And as I mentioned, like about the viral thing, again, I have been promised that they will be giving me a coverage of tissues as well. But as of now, no, we are not covering the histopath sample.
So there is some good news, Aneesh, as we talk, okay. And I was about to bring this up with you. Okay. We have in the past 1 or 2 days handled tissue samples.
Oh, great. Okay.
So we were just waiting for the results, and the results look good. Specifically with respect to histopath samples, the only care has to be, it shouldn't be in formalin when this test is being ordered. Definitely. So I think the tissue needs to be in the sterile normal saline. That's probably the need. So it shouldn't be a formalized tissue.
Right. Okay.
But someday I think, Aneesh, we'll need to work our way around that too.
Yes, because most of the onco samples will be FFPE tissues. So we need to have a look at that. We will be. See, that's what technology is all about. Every day there's a new update. See, this is a new update for me. Along with all the viewers, I think
Yes.
I'm getting updated on this. That's good. Congratulations to you and your team.
Thank you. Okay, a lot of questions. I mean, this is great. May I understand that number of reads equals the concentration of the organism, which will also help in designating as commensal or pathogen? Not really.
This is what we have been saying, that we can't judge that.
It's the depth of sequencing. It definitely is not quantitative, but from the depths, there are statistical analysis and methodologies which an expert bioinformatician can work. And as the test adoption goes on increasing, we have more cut sections of various clinical samples. We will be able to devise a quantitative rule for it.
Right.
Today, no, we shouldn't.
I think that's the case, like iPhones release every year. Similarly, probably infexn will have version 1, 2, 3, and so on and so forth.
Yes. Right.
Okay.
But I think Amol writes, but technology uses 16S and 18S. I'm sorry, I probably missed the link to what you are trying to say.
Technology uses 16S, RNA, and 18. Okay. That looks like something to which he's connecting, but I don't know what he actually meant.
Per se, we do not use 18S for the fungus. Right. It is IPS. I think we have covered most of it. Rather all of it.
Oh, great.
Okay. False negative percentage. There is another one. False negative percentage.
Where is that? Who's
This is Soma Rajan Tajan Anandan.
Okay. False negative percentage, I think I'll give it to Dr. Mahua, because what from my experience here would be limited to judge that. I think you have been looking at multi-centric results, so I think you will be able to give an answer on the false negative percentages.
Okay. So when we talk about false negative, and if I say something is a false negative, then first I need to understand what is the gold standard I'm comparing it to. So if I'm comparing it to culture techniques, where culture has picked up, but we have not, or this technology has not, this hasn't really happened. When it has happened, and when we went back and investigated, because this is a red flag for us, for a sensitive, something as sensitive as NGS to not be able to pick up when culture has, is a red flag for the entire team. What we have found is that the draw sites were different, or the draw times were different, or the volumes processed for both the technologies were different. So to quote some examples, there was a case where the volume that went into the culture was nearly 10 ml, and that sourced for this test was a compromise. It was only 2 ml. So normally we never recommend low volumes, post which the clinician and the microbiologist themselves specified and emphasized that volume is very important to be stuck to in this case. That was one of the false negatives that we have experienced. The other was when we called out a negative, the culture was positive. On talking with the microbiologist and the clinician, again, we could find out that for culture, the central line site was used to draw the sample. We were given from a peripheral site. So that was another case. The third was different draw times. So culture was performed. The bottle flagged positive. Patient had already been started on empiric antibiotics. The bottle flagged after around 24 hours, post which the blood was taken for infection test. Now, by that time, the load must have gone down below the limit of detection. So these were 3 instances where on the face, it appeared as if these were negative, where culture was positive. But diving deep, we found out that there were definite causes for it. As a technology, it is very sensitive.
Okay, I think that answers. Okay, I think.
How much CSF is required?
Okay, so the suggested quantity is 4 ml, which is generally said. But then, yeah, we have seen results with even 2. I think lesser than 1 is where we were not able to get and pick up anything. But then we have seen with 2, in my experience, I don't know about the other centers, but in my experience, we have seen with 2. But we generally prefer, because this is something which you can't keep asking for a resampling in case of any emergency. So we generally prefer it to be at 4. So blood is 8, and anything apart from blood is 4. That's how it is.
Right. Is NGS available for research purpose? Yes, very much. Very open to research. Dr. Aneesh is an excellent collaborator, so I'm sure he can take up any research that comes his way. Okay, I think we have actually sort of addressed all the queries. I request the participants to please go to the polls, and this helps us improve each time. So.
Oh, I didn't know you have a poll option. I hope they give a good option. I mean, opinion.
Okay, this time we don't have. Normally we do have. So
okay.
I'll just check with Harshit.
Yeah.
Harshit, do we have a poll? You can put it on the chat box, a yes or a no. Then we can close the session. Oh, we don't have a poll this time. So Aneesh, you score 100.
That's like being the only student in the class and being a topper.
Yeah. Okay, great. Any studies in immunocompromised host?
Yeah,
I think because all our samples are being sourced from the ICU, very much an immunocompromised cohort.
Yeah, and even studies, even published studies, there are plenty available on immunocompromised hosts. I mean, I think that's actually the whole intention, where this is where we can filter to all categories.
Okay. Aneesh, if you just give me another 30 seconds, I'll scroll through to see whether we have missed anything. There is one, can we use in virus mutation analysis? Once the viral panel is there, I think we will be in a better position to address. But this is a discovery platform, so anything that comes our way should be taken care of. To my understanding, we have covered all of it.
Yeah. Abhimanyu has sent a text saying more
questions. Yeah. That's why.
I'm sorry, but both of us are not able to find which questions you're
Yeah, Abhimanyu, if we have missed something, you can just copy paste it for us. We can't see anymore.
I think. Oh, no, all answered. Okay. So
thank you. So Aneesh, thank you so much. Thank you so much. It was fantastic. And really enjoyed the session.
It's a pleasure always connecting back and sharing a little bit that I know about this. Thank you, and wonderful audience for being. I mean, I think the biggest thank you goes to the audience for being such an interactive one. I mean, I've given webinars, but then this is kind of a wonderful audience where everybody has been interactive. So many questions. Thank you so much for that. I am happy that you were listening and did not sleep off. Thanks, Dr. Mahua, for
thank you.
And thanks to his text team.
Have a great weekend. Thank you, team. Signing off. Bye.